Hello, good afternoon to all those that have joined in our today's Pediatric Emergency Medicine lecture series. And good morning to our colleagues who are in the US. We'd like to say thank you for taking your time to join in our today's STEM lecture series, where we're going to have another interesting topic. And our topic today is going to be an approach to pediatric seizures in emergency setting. And we're going to be having two presenters. We're going to be having Dr. Asha Iyulu, who is a Pediatric Emergency Medicine Fellow at MUHAS. And we're going to have Dr. Colleen Fant, who is an Assistant Professor in Pediatrics at Northwestern University. So just to remind you, we always have our PEM lecture series every month. And we always speak of pediatric topics that are commonly like to be presenting at our acute setting or at our emergency department. So always keep reminded that it's every month, and we warmly welcome you to join in as we keep on learning about pediatric emergency medicine. This is a CPD accredited activity where we have 3 CPDs. But again, as we all know, for those that have joined in, we still have technical issues with the MCT website, especially claiming the CPD points. So still bear with us. We are, as long as the MCT team is still working, so that we could all claim your points. As of now, I know we have 2 PEM lecture series that have not been able to claim the CPD. And this is because the MCT website is still having some technical issues. But rest assured, once everything is settled, I'll make sure we all get our CPD points. All these lecture series that we've been conducting are all recorded and posted in our YouTube channel in case you want to go back and learn, or you missed any of the sessions that you wish to learn. You can always go back to our YouTube channel, and I'll share the link in the chat box for everyone to access it. So now I would like to welcome our 2 presenters to begin the presentation.
Hey. Hello, good afternoon again. My name is Asha Iyulu. Pediatric Emergency Medicine Fellow at Muhimbili University of Health and Allied Science, together with my fellow doctor.
Hi, I'm Colleen Fant. I'm one of the assistant professors of pediatrics and a specialist in pediatric emergency medicine at Northwestern University in Chicago, United States.
Hey, today we're going to talk about approach to pediatric seizures in the emergency setting. And thanks for having us. Right. So this our learning objectives. At the end of this session, we're expecting you to be able to define seizures and status epilepticus in pediatric patients, to be able to review the pathophysiology of status epilepticus, and also clarify the importance of timely management of status epilepticus, and also understand the definition and appropriate evaluation of febrile seizures, understanding the standard algorithm-based management of status epilepticus, and also consider the application on individual day-to-day practice. We'll start with a case. This is a 14-month-old female baby was brought to you, actively seizing on arrival, has bruising on evaluation, has a bruising on a skull, and a deformity and swelling on the left skull. What are your concerns about this baby? The baby is actively seizing in front of you. The answer to this, we're going to get it throughout the presentation. Thinking about the pediatric seizures, why do they matter? Number one, pediatrics, they normally have the immature brain, and it's more prone to seizure than in adults. Luckily for children, they normally outgrow the seizures, certain type of seizures, not all of them. And seizure is one of the neurological emergencies, so you need to manage it as quickly as possible so that you can avoid neurologic harm on prolonged seizing activity. And also you need to do rapid stabilization and also evidence-based workups. It's not all of the seizures that you're supposed to do thorough evaluations or examination. I mean, like lab evaluations or imaging. You have to, there are some seizures that you might not even do the imaging. And also, providers caring for children should be able to identify seizures and differentiate seizure types, know how to keep children during seizure. I mean, how do they keep them safely during the seizing episode, and how to stop the seizure itself, and to know the underlying causes, and also how to prevent neurological injuries that could occur after a prolonged seizure episode, and also to understand the disposition plan of this patient with seizure. And so you should know that almost 5% of children will have at least one or more than one episode of seizure by the age of 16. So it's very common. That's why you really need to know what it is, types, and how do we manage it. It's very much unfortunate that seizure in children may be less so obvious compared to adults. They might present with just eye deviation or just deviation of the head, lip smacking, tongue biting, or they can come with a fully like rhythmic and jerky movement, which we normally see. And sometimes they present with episodes of apnea and cyanosis, as the baby we can see here. Now we need to know the definitions of different seizure events. Number one, we need to know what is a seizure itself. It's a paroxysmal event that is characterized by transient occurrence of signs or symptoms due to abnormal, excessive, and synchronous neuronal activity in the brain. While status epilepticus is defined differently, that is a single unremitting seizure that is lasting more than 5 minutes. Or if you have frequent, more than one seizure or recurrent seizure episodes that occur without returning to the baseline state in between the seizure episodes, that is status epilepticus. On the other side, we have epilepsy, which is occurring of more than one episode of unprovoked seizures that normally occurs more than 24 hours apart. Maybe you can have one unprovoked seizure today, after maybe a week or so, you can have another unprovoked seizure. We are worried that you might be having epilepsy because your seizures are unprovoked. They don't have any other problem. Maybe there's some problem with the brain neuronal activity itself. And the last definition is the seizure mimics or epilepsy mimics. These are the things that you really need to rule them out when you're managing your patients, because with the population of pediatrics, they can present with symptoms that looks like seizure, but they're not seizure. One of them is a syncope attack. This is actually transient loss of consciousness, but they normally regain fully consciousness after the seizure episode. So, I mean, after the episode of loss of consciousness. So it's not a seizure per se, but it's something that look like a seizure. So you might be tricked and think it's a seizure and give them the anti-seizure medication, which could be having deleterious or bad side effects. Others are like breathing, holding spells, which occurs in very small babies, mostly when they are angry, or all these are psychogenic related kind of activities that you really need to know them and rule them out before you start managing or giving them the anti-seizure medication. Okay, other part we really need to know is about the classification. Seizure classification is actually based on where does this seizure come from. Like it can be generalized seizure. It has a generalized onset, where the whole brain is involved at the onset of the seizure. And it's actually, which resulting with immediate loss of consciousness after the event. This can either be a convulsive or non-convulsive. The convulsive one are the most common, like tonic, clonic, or the clonic kind of seizures that we normally see. While non-convulsive, we also have the tonic or absent seizures that we see in pediatric population. And a focal seizure now is the one that involves a local like a localized part of the brain that is involved. It can either be simple or a complex partial seizure. For a simple partial seizure, they also call it a focal aware seizure. There is no impairment of consciousness in this kind of seizure. Patient will experience unusual, whether it's motor or outside autonomic activity, but the consciousness stays intact. While for complex seizure, they normally present with abnormal movement with altered mental status. And focal seizure can also progress into the generalized seizure. That's what they call secondary generalization of the focal seizure. But it's still a focal seizure because the source or the initial source of the seizure was actually focal. All right. After that, we need to know the febrile seizure, which is one of the most common seizures that we see in the pediatric population. It occurs in 2 to 5% of children with seizures. This one is a clinical diagnosis. It's actually can be diagnosed without any lab or imaging studies, though it is also a repetitive seizure, but it's not considered as epilepsy because it has a trigger. The fever must be there. The things that the criteria that you have to consider to say that this is might be a febrile seizure. Number one is temperature above 38 at the age of 6 months. Also age between 6 months to 6 years. That's the age of onset, and also no history of previous febrile seizure if that's the first onset. Absence of CNS infection or inflammation like meningitis or encephalitis, and also absence of any acute systemic or metabolic abnormalities that are seen. That those are the criteria that makes you think this is a febrile seizure and not otherwise. And when you're thinking of febrile seizure, you should make sure that this patient is not epileptic, no any intracranial shunt, no any cardiac lesion, especially the right to left cardiac lesions, the cyanotic one, and there's no any oncological oncology or any other malignant illnesses that the baby is having. That's when you can say, okay, I have to exclude this before I say this is a febrile seizure. There are two types of febrile seizure. It can either be a simple febrile seizure or a complex one. For simple febrile seizure, actually, they normally present with one episode of seizure in 24 hours that lasts less than 15 minutes, and it is generalized kind of seizure. While for complex seizure, they are always focal, lasting more than 15 minutes, and they can present with more than one episode of seizure. Actually, they present with more than one episode of seizure in 24 hours. Okay. How do we manage febrile seizure? Starting with a simple febrile seizure. First of all, you need to, most of the time, all right, in general, 80 to 90% of patients who are seizing, they normally come out to, the seizure episode stops in less than 5 minutes. So by the time they reach to you, if it was a simple febrile seizure, by the time they reach to you, maybe they're not actively seizing. So you need to confirm if they have returned to baseline, and ensure that the patient has normal neurological examination at the time you're evaluating them, and also perform a simple evaluation for underlying or treatable causes of fever, because fever was the trigger for that seizure to happen. So you need to evaluate for maybe if they have any UTI or any upper respiratory tract infection, make sure you treat it before you continue. And there is no indication for routine labs or lumbar puncture or EEG or imaging in this kind of group of patients. If they had only one episode in the past 24 hours, you observe them. If they're okay, you can ideally discharge them. Okay. This, while you're discharging them, you need to, there is no need of giving them anti-seizure medication for this group of febrile seizure. So you need to just educate the family on how to take care of the patient when they are when they are having convulsion, and also you need to explain to them on the risk of recurrence, and also when to come back in case the baby is seizing or there is any other thing that is abnormal that has been happening to the baby. And on the complex seizure type, you need also to confirm if the seizure has stopped and the patient has also returned to the baseline. But for this group of patients, because they're seizing and there's recurrence of seizures within the 24 hours, so you need to do some evaluation like imaging. You can do imaging, you can do the urine testing. You can consider spinal tap like lumbar puncture if they're unvaccinated, and if the exam findings concerning maybe they're having some sort of infection, you have to do the lumbar puncture. Also, you have to do EEG, but this one can be done as an outpatient. Okay, and for this group, if they have complex seizure, febrile seizure, so you need to admit this patient. And admission is mostly based on if the findings are concerning that, or the testing that you're done that concerning that this patient may be having an infection or something else other than just the febrile seizure. And also for this, when in case you're discharging them, you can consider giving them the rescue medication, because by the time they arrive at the ED, they might have convulsed for more than the time they're more than even 15 minutes, and that is dangerous for their neuronal viability. And also you teach them on the seizure safety and also when to come back. Okay. What are the risk of recurrence? For simple seizure, have 30 to 50 chances of recurring if the time of presentation of the seizure, the child was very young, they say less than 18 months old, and also if the time between the fever onset to the episode of convulsion is less than an hour, they have a risk of recurrence. And if the convulsion happened, when the fever was less than 40 degrees Celsius, they say they have a chances of recurring. And if also the first degree relative has a febrile seizure, there's also the chance of a patient with a first episode of febrile seizure to have a recurrent seizure. And during if they had if the baby had an episode of febrile seizure, giving them antipyretic even if they don't have fever does not reduce the risk of seizure. So if you manage fever when they are febrile, if they're not febrile, there's no need of giving them around the clock antipyretics, because it does not reduce the risk of seizures. And what are the risks for epilepsy? For patients with complex seizures, they have 8 to 50% risk of going into epilepsy. And for simple seizure, the risk of epilepsy is around 2%. All right, from there, we're moving to status epilepticus. This is actually, they call it the ticking clock. Actually, as we have said in the definition there, it's a seizure lasting more than 5 minutes, or you have 2 or more seizures without recovering of baseline state. There is the threat is that there's a 5% risk or increased probability that the episode of seizure might last more than 60 minutes. With each minute passing from the time the patient starts presenting with seizure to the time of ED arrival. So most of the time they don't come to the ED immediately, as in they're seizing. They take time until they reach to your ED. It might take time. If you collectively collect the time that they've been seizing, it might be more than even an hour. So whenever they come to you, they are seizing, assume they are most likely on a status epilepticus because they started seizing from home, not where they are at the ED. And the chance, mortality is around 2 to 5%, but this one depends on the etiology of the seizure that was been there. Now, when the baby convulses for a very long time, they're using, the muscles are, they're repeatedly moving. They end up with anaerobic metabolism because after a while they're going to overuse the oxygen they have. They end up with anaerobic metabolism. They end up they'll end up with acidosis. They end up as hypoxic. They will also retain carbon dioxide because the respiration will be impaired. So they'll have also respiratory acidosis, and there'll be increase in intracranial pressure, and all of this lead to neurologic damage, which is the thing that we normally fear and we're scared of if they seize for a very long time. So the target here is to administer medication at 5 minutes, okay? As I mentioned earlier, 80 to 90% of the patient with generalized tonic-clonic seizure will normally spontaneously go back to normal state by the seizure will stop within by 4 minutes, mostly within 2 minutes. So if seizure persists more than 5 minutes, it's unlikely to stop without treatment. So just so you know, if they have been seizing at home and they came to you, they've seized 3-4 times, make sure that you're ready, you give them the medication immediately to avoid further neurological damage. Looking at this is how the pathophysiology. Initially, when they have like 2 phases. Phase 1, we call it a hyperdynamics phase. The second phase is called the exhaustion phase. And during the hyperdynamic phase, there is increase in metabolic demand in the brain. So there will be increase in cerebral blood flow, and this is to meet all oxygen and glucose delivery. And also there will be stress hyperglycemia at this situation, okay? As seizure continues from 20-30 minutes, as the seizure continues, the brain ability to cope with this demands actually fail. They enter into exhaustion phase. The oxygen demand is still high, but the ability to deliver that oxygen is failing. So the autoregulatory system is actually failing, even though the demands of oxygen is high, even the glucose demand is on the higher side. So at this time, cerebral blood flow also falls down, and also the patient will be having hypotension, and the body will not be able to supply the glucose and oxygen as required. So as they continue with inability to supply both oxygen and glucose, the neurons are going to suffer. And at this phase, that's where they're going to have permanent neurological damage as they continue. Okay, so when looking at the differentials, what could be the cause? What could be the cause for seizure? As I said, seizure is just a symptom. It's not a disease. There is some things that are happening in the patient that are causing the seizure, okay? One of them, have a very quick mnemonic called vitamins, if you have to remember it easily. If you have a seizing patient, think of maybe vascular issues like, are they having a stroke? Are they having a vascular malformations? Are they having infectious process like meningitis, encephalitis, and the rest? Or are they having hypoxic ischemic events in the brain or traumatic brain injury itself? Or do we have anything like a tumor? Or do we have a toxicology? Or do we have metabolic issues? Like these are the most common ones. Like we normally present with hypoglycemia, hyponatremia, hypocalcemia. So this is quickly reversible. Even the other ones you can treat them, but you really need to be sure that these are not there, or if they're there, you have to treat them as quickly as possible because they could be one of the trigger for seizure to occur. And for the patient with maybe hyponatremia, hypocalcemia, hypotoxicology, they normally don't revert to normal unless you give them what is required. If it's an antidote, you have to give them an antidote, then the seizure will stop. Or if it's hypoglycemia, you have to give them glucose so that the seizure will be able to stop. So at the ED, what do we do? Number one, we need to think of any prolonged seizure as an emergency. It is a medical emergency. It is a neurological emergency. Think of that. You need to stabilize the ABCDEs, but don't forget the glucose always. You need to get an IV-IO access. Or if you don't have this, it's not a problem. You can use intranasal if you need to give them anti-seizure medication, but make sure you get the peripheral IVs after that. You need to monitor them, have your benzodiazepine, and also anticipate difficulties in the airway because they're prone to aspiration, and also being through a lot of therapies. They might have also respiratory depression. In the first 5 minutes, one thing to consider is SAID ABCDE, vascular access, oxygenation, and don't ever forget the glucose. Okay, so the airway, place them on the lateral position. Make sure that they're not aspirating. Okay, you can either put a shoulder or you can do the jaw thrust just to open the airway. And also you need to administer supplemental oxygen if you have kept them on the monitor. Give them oxygen, whether it's through nasal cannula or rebreather mask, and you need to have a continuous monitoring and IV access. But if you don't have IV access, you can give, as I said, you can give medication intranasally like midazolam. You can give IM or buccal or parectal as needed. Also, if they're actively seizing now, what do you do? Most important thing, avoid aspiration. So put them in lateral position. Suction, ensure the airway is open. And also avoid disabilities. They're having already a disability seizure that they're having. Avoid further disability. So if they're in a bed, make sure you pull the side rails, make sure they're not falling down. If they're down, maybe they're on the floor, they're sitting on the floor, put some padding on the head so that they will not get any trauma while seizing, because that's a possibility too. You have to think of that too. And give the benzos at 5 minutes of seizures. And okay, this is the flow. As any other patient in the emergency department, number one thing you have to do, identify if they're in any distress, and immediate non-specific management, as we say, the airways, breathing, circulation, the peripheral IVs, and also do further history and evaluation, and also you will end up with your diagnosis. This is what you're going to do in the airway. The problem, they normally become hypoxic due to hypoventilation. So you need to, now they also have disordered control of their breathing, inability to maintain the airways. So make sure you position them correctly, provide them ventilation if possible, and give them oxygen support with adjunct therapy if you can. So if they have trauma, you can do jaw thrust maneuver. But if they don't have trauma and you're sure they don't have trauma or history of trauma, you can do chin lift head tilt, as you can see in the image. All right. Also, on history, patient is seizing in front of you. After you have given your medication, what do you need to know? You need to know, do they have any medical problem that could have been the trigger for whatever seizure that is happening? Or has they have any history of seizure before, history of trauma, any ingestions like toxins or some medications? They can even take a single pill and cause them to convulse. That situation can occur too. And also any prior history of using over-the-counter medication, or are they on any anti-epileptic medication? Is there any change of dose? Are they on subtherapeutic doses? Or did they miss any dose? You really need to know that in your history. While in a physical exam, you need to examine, do they have any swellings or deformity in their head, any history of trauma, any shunts, because maybe they have history of hydrocephalus, they have a shunt, and now maybe it's infected, they're convulsing. Also, the next check for the signs of meningism, C-spine injury, On the eyes, check if they're still seizing. The eyes could be deviated. Possibly they have a started epilepticus that you're not seeing the jerky movement, but it's just the eyes that are deviated. So you really need to reevaluate the eyes and see what is happening, and also check on the pupillary reaction to light. Are they reacting well? Maybe they could be a toxidrome. Maybe they're pinpointed, or one, and if they have an isochoria, they'll tell you if they possibly they have a space occupying lesion or anything. And a neurological examination, you also have to check on the symmetry on both faces and extremities. Maybe they had a history of stroke or something, and check if they have any dysmorphic features. It could be a sign that they have maybe neurological congenital malformation too that you didn't notice. And also another thing is respiration. Is they are seizing, they have a higher risk of aspiration. So they might be having aspiration pneumonia. So check the respiratory system and rule out that. And per abdomen, since pediatrics include teenagers, for the girl who's seizing and she's a teenager, consider eclampsia too. So check if are they pregnant or not. All right, level of consciousness, it will tell you what kind of seizure they have. If it is, they normally, in a usual time, they normally present with mild decrease of level of consciousness, but this one actually resolve over time after a true seizure event. But for those who had maybe the seizure mimics like a syncope, they will wake up immediately and do like nothing happened. Now you know this is maybe it was not a seizure, it was just a syncope, which is another seizure mimic. Okay. And also reflexes on your examination. The hyperreflexia tell us the electrolytes are normal, like maybe magnesium or calcium. Also things like alcohol withdrawal, which we can see it in neonates when the mother was alcoholic during pregnancy. When the baby is, they might present with alcohol withdrawal symptoms. Yes, other things like also tremors, electrolyte abnormalities, and also on the withdrawal syndrome. It's a possibility. Another things you have to do is motor on the neurological motor examinations. So if they can present with thought paralysis, that is a short-lived focal neurological deficit that occurs after a seizure. So they present like a stroke-like event, but it normally resolves with time. So you have to examine presence of it and also document also. Random movements like in a pseudo seizure activities, they normally have random movement of extremities, one limb, then after another limb, and they normally vocalize before they have this episode. So you have to examine if they have this kind of movement. So you think, oh, this might not be a real seizure, it might be something else. Maybe it's a pseudo seizure activity, things like that. Okay. From here, Dr. Colleen can go ahead.
Yeah, hey, thank you, Dr. Asha, for that incredible summary, and kind of highlighting how important it is to identify and treat these appropriately. So we're going to kind of go through what happens when you have the child who's being seen for status epilepticus and how you're going to investigate potential underlying causes. Have you next slide?
Okay.
If not, I can also share.
Okay, go ahead.
Okay. So I just wanted to highlight the kind of the laboratory-based workup in children. So kind of like when I think about sending tests in kids, I always want to think about why am I doing it and how is it going to change my management if it's going to do so. So while any child who comes in with status epilepticus is going to get an evaluation, I just also want to highlight that many of these children may actually end up with normal labs and imaging. So when you have a kid status, you are probably going to be getting basic labs in most patients, and that's recommended. And then there's some specific ones you're going to do in specific populations. And then just kind of really highlighting timeliness of labs. So we know certain labs come back immediately. So point of care testing like glucose and certain blood gas testing versus more longer term labs like full blood pictures. Next slide. So when you're sending laboratory evaluations, really what you're thinking about are what are some reversible causes of seizures. So thinking about metabolic etiologies like Dr. Asha mentioned, obviously hypoglycemia you want to treat. Many blood gas analyses, if you have that point of care, do also include sodium, calcium, um, levels that you can get. You can also send a magnesium level, which will take a little bit longer. And then looking for things like liver and kidney function in the setting of potentially overall organ dysfunction, and that those levels can also be used for future anti-epileptic medication planning. Also sending labs looking for treatable causes, so kind of what triggered the seizure to start. So kind of sending your HIV and your malaria smear. We typically recommend a full blood picture for these patients, but it's often not diagnostic and can be more of an adjunct. And I always like to highlight for my learners that you can have a post-convulsive leukocytosis, which is actually pretty common in about like 1/3-ish of children. So that may not be leukocytosis from infection, but from the seizure itself. And then thinking about those children who are very sick or have specific risk factors, and those are the kids you might be thinking about lumbar puncture with CSF studies, Kirk-Shakopple antigen testing. And then if there's something else based on your history of physical exam that has come up. So for those patients who are known to be taking an anti-seizure medication, what is their current level and is that why they seized? Did they seize because they had an intracranial hemorrhage, thinking about bleeding testing? Children with no metabolic disorders or children who have a history of liver, kidney dysfunction, or heart dysfunction. Next slide. So just overhead. So if depending on kind of the resources will guide your more advanced testing potentially. So like I said, not every laboratory has the ability to send different anti-epileptic levels, but if you do, sometimes that can help guide future treatment. Kind of depending on your history, if there's concern for different types of exposures, that might be warranted to send. And then if there's a risk factor and you have the ability of thinking about herpes, viral testing in children can be helpful, particularly if you have like prolonged focal epilepsy and the child is very unwell appearing. We think about the role of ECG in the evaluation, and often isn't helpful in the diagnosis of seizure itself, but it can really be helpful if there are electrolyte abnormalities you're worried about, or dysrhythmias and strokes, or if potentially seizures on your differential, but you're not sure because some acute dysrhythmias can precipitate mental status changes. Next slide. Okay, so thinking about head imaging. So really all pediatric patients with a first time afebrile seizure should have head imaging done. So if the seizure has stopped and you have the time and the patient is stable, it becomes less of an emergency, like you have to do it this moment. And you may have the opportunity to like admit the patient for head imaging. And if you have the resources, an MRI is often a first line in a stable patient. Obviously, if the patient is unstable or unwell appearing, you're going to be getting a CT scan because that will get you results much faster. Other children we would recommend getting head imaging would be kids who are known to have epilepsy, but may have some change in their disease or severity. I think a lot about head imaging in the neonates because they are at a higher risk for like hemorrhage, stroke, or congenital abnormalities. Any child who has signs of elevated intracranial pressure, either on your exam or your vital signs. And then children with underlying medical conditions like malignancy or immunocompromise. And then really one of the things you're looking for quickly when you're getting your CT scan are looking also for focal lesions like a bleed from a ruptured arteriovascular malformation. Next slide. So other investigations that can be really helpful in taking care of these children are really getting that EEG if it's available to have it. Obviously, they're not something that are easily interpreted, so you need that neurology specialist to be able to review the findings. So in the acute seizure moment, it's often not that helpful unless really you can't tell if the patient's in status or not, or they are known to be in status and you aren't able to follow your clinical exam. Um, but really what it can be helpful for is to characterize the type of seizure and the type of electrical activity that's present. And then for children who have that kind of first time seizure or new seizures, it can help determine what their predisposition might be to more seizures and help you choose kind of the right drug for them. I think this is most useful in the very emergent or acute setting if you have that child with unexplained altered mental status, or you have that patient in status epilepticus and you've had to intubate them, sedate, and paralyze them because then you are no longer able to follow your clinical exam. Next slide. So thinking about management. Next slide. So just to kind of bring this back up, talk about medications, but I just want to highlight you're managing the airway first. While someone is getting your medication vials, drawing out, calculating the doses, there needs to be someone at the bedside managing that airway. Next slide. Next slide. Again, thinking about those reversible causes very quickly. All right, so the kind of first line medications, we really like to use benzodiazepines, really both in kids and adults, but this has been found to really be the most successful. The kind of three that we have here, you have your lorazepam, which the dose is 1.1 milligrams per kilogram with a max of 4. And you are going to want to administer this over several minutes because all of these benzodiazepines are going to potentially increase the risk of respiratory decompensation. Your other two options that you have are diazepam and midazolam. Um, Ativan, or sorry, the lorazepam can be given IV. It can also be given intramuscularly if you don't have access with different dosing. The Valium or the diazepam can be given intravascularly. It can be given per rectum. There's also the ability to oh gosh, I'm blanking on the world. Give it via like a nasal spray, similar to the midazolam. Just blanking on the word. I think I just had a stroke. And then the dosing here. So there's actually different dosing if you kind of look through the literature. The midazolam dosing, I have seen like generally the 0.2 mg per kg. The diazepam dosing, I have seen some ranges of 0.1 to 0.3. It can be really helpful to reach out to your local pharmacist to kind of determine what their preference would be for the institution to kind of make a guideline. And just a quick note about the different benzodiazepines. So the benefit and kind of like harm between the two are really about how quickly they work and how long they last. So they both have pros and cons. So midazolam does work faster, and it leaves the body faster. So you also are able to get a neurologic exam quicker. However, if you're worried about kind of seizure recurrence, that lorazepam will actually last a little bit longer. So while your exam is less reliable going forwards, it will have a little more effect in the body. Next slide. All right, so what we kind of think this through is you're giving that first line medicine at 5 minutes, and then if that seizure is still not broken by 10 minutes, you're moving to your second line agents. Obviously, if you don't have these agents available, but the patient is still seizing, your other option is to repeat that first line agent, the first line benzodiazepine. However, if your patient is still seizing at 10 minutes, these are really the preferred model of treatment. So they're all pretty equivalent. They just have different side effect profiles. So it's really institution dependent. I know, for example, my institution prefers fosphenytoin as the second line. There are many institutions that prefer levetiracetam as the second line. So we put up the dosing here. So the fosphenytoin works by affecting that brain activity. You can give 15 to 20 mg per kilogram. I usually do the 20 milligrams here, and you want to administer it slowly because fosphenytoin is known to cause hypotension in patients. So the when you kind of give it slower, that does help kind of decrease that risk. Um, the other option that it's used very frequently is a levetiracetam. You can actually get pretty high doses in children without significant side effects. So that's why many institutions do like that medication. Most preferred dosing is between 40 to 60 mg per kg. You are also going to still give that over 10 minutes, similar to the fosphenytoin if you're able to, but you tend to see less of that hypotension. And then some institutions do also use the valproic acid as their third line with the dosing here of 15 to 40 mg per kg. Also tends to be pretty well tolerated. So all these three are pretty known to be non-inferior to each other. So you're not wrong going with either of them. It's just the side effect profile and availability. Next slide. So kind of third line interventions. So once you've gone through your benzodiazepine and your second line interventions, You can actually repeat those second-line interventions. You can give additional doses of fosphenytoin. The dose does decrease for your second dose to 10 mg per kg. You can give an extra dose of levetiracetam, but then you're also thinking about additional agents. So this is when you can use some of your resources, and if potentially if your institution has like a pathway you can follow of what your next line might be. Phenobarbital is often thought of as a third line. You just do need to be careful with it. It's a little bit more sedating than the others, and it does last a lot longer. So if you do get negative side effects from it, they will be occurring longer in the body. Another medication to consider if you haven't stopped your seizure after that 15-minute mark. So again, at the 5 minutes, you've given your benzodiazepine. If you still haven't stopped seizing by 10 minutes, you have done your fosphenytoin, your levetiracetam, or your valproic acid. And then by 15 minutes, if you haven't stopped, you're thinking about either repeating those second lines or additional agents. So pyridoxine is also one we always think about for the rare patient who has specific deficit in this vitamin. Next slide. So if you still haven't broken your seizure after giving kind of those third line and fourth line agents, at some point you're thinking about, how do I manage this patient going forward, and how do I make sure they don't get continued harm from it? Obviously, the goal continues to be attempting to stop the seizure, but at this point, you're doing more advanced medication management, including continuous infusions, and you're also at this point likely taking over the airway. So by that I mean if that patient has been seizing for more than 30 minutes, they're unlikely to be able to really keep their airway patent. And at that point, they're unlikely to really be able to maintain all their hemodynamics, including blood pressure and oxygen. So there's a couple different options you can do with these continuous infusions. One of the most common ones is using a midazolam infusion with a loading dose followed by an infusion over time, and you titrate or calibrate that to the patient's seizure activity, which can be very difficult if you have a sedated and or paralyzed patient who is intubated. So this is one of the reasons EEG can be helpful. Other options you have are phenobarbital and propofol. One option we do at my institution as well is we do ketamine infusion. So you can start with a loading dose of 1 milligram per kilogram, and then follow that up with an infusion of 10 micrograms per kilogram per minute, and kind of again titrate that to effect. Next slide. And at that point, those patients are going to the ICU. So I just wanted to specifically call out neonatal seizures, and this is seizures in the under 28-day-old patients. And the reason I call this out is because there's a little bit different, more common pathophysiology that you see in them. So your evaluation approach changes, and then your treatment approach is actually a little bit different. So these children, as we know, are at much higher risk for infections, including neonatal sepsis, meningitis. They also may have sequelae from birth, like birth trauma, hemorrhage, or neonatal stroke. We know that children who potentially had hypoxic ischemic injury during birth have a little bit higher risk of seizures. And then this is often the age when some of these inborn errors of metabolism we all learned about kind of back in medical school may potentially present themselves. So when substrates the body can't break down, kind of really start building up, accumulate in the brain, and that can precipitate the seizures. So in these children and these patients under 28 days with status epilepticus, I'm really thinking a lot about sepsis. So we know that's one of the more common causes of this. So I'm going to be evaluating the patient for it and treating the patient for it. One thing I always worry about is also HSV infections, because they can be incredibly detrimental to the child if left untreated. And these kids are really the ones you want to think about head imaging as well, because they can have that acute bleed, they can have that acute stroke that you might need to intervene upon. And again, you have your typical metabolic testing that we reviewed earlier. These are the children you may think about that more advanced or broader metabolic testing, looking for some of those diseases and inborn errors of metabolism, and looking for those substrates that can build up, like glucose, lactate to pyruvate, amino acids, etc. The treatment is also different in this age group. So there are some institutions that do still use benzodiazepine as their first line, but kind of overall reviewing the literature, this general consensus still be that phenobarbital is actually your first line agent. So you have that seizing neonate, so under that 28-day mark, the first medication you're going to want to give them is phenobarbital. If that patient has been seizing for a prolonged period of time and you don't have phenobarbital, you are still going to give that benzodiazepine. If you do have the phenobarbital available, that is your first-line agent. You're going to do that loading dose of 20 milligrams per kilogram, and then have some sort of follow-up plan with your dosing over the next 24 to 48 hours. And ultimately, that patient will likely go home on phenobarbital. These children, obviously, you're thinking about pyridoxine. Next slide. So I just wanted to take a quick moment to highlight, kind of in the review of the literature, what are some of the standard of practices around treatment of pediatric status epilepticus. And in many places, institutional algorithms are utilized to sort of standardize the treatment and approach to this disease. So there is good data to support that having an algorithm that the staff uses, caveat there, does shorten time to medication administration. It is shown to reduce medication error. And then most importantly, reduce total seizure time of the child, which we know is how you preserve that brain and reduce the need for intubation. Next slide. So this is the one that exists on the EMAT application on your phone. It's from Arusha Lutheran Medical Center. And you can see some of these dosings are like slightly different, and it's really institution dependent. And most institutions, when they develop these algorithms, as we all know, will work closely with pharmacy to confirm dosing. So this is just what they use, and you have available to you on your app if you have it on the phone. Next slide. I just wanted to highlight this is the one that I use at my institution, which is a little bit busy. It's not my favorite, but it sort of breaks down roles too, which allows you to sort of simulate this with your training to make sure everyone knows their roles in status epilepticus. Next slide. And then this is another one from the from EMAP. So again, first line benzos, second line in this algorithm is phenytoin or phenobarbital. And that's why we talked about a couple different second line agents, just because it really is what you have access to, and kind of making sure that at the institution, if everyone has the same second line agent, makes it very easy for people to streamline care. Next slide. So disposition plan. So it really depends on the cause, the seizure type, how long it's lasted, and what the child looks like. If a child has returned to baseline, is normal, happy, playful, and you've done your appropriate workup, that child is often able to go home. And kind of thinking through how you're going to treat them going forward, whether they need anti-epileptic agents, whether they need rescue medications, or they just need really good teaching and follow-up. Obviously, those patients who are actively still seizing, have an abnormal neuroexam, or have some concerning finding like an infectious etiology or hemodynamic instability, you're going to be keeping in the hospital. Um, for those kids we know have seizure disorders who are known to be on seizure medicines, it's always really helpful to talk about, why this happened and make sure that the patient's family's doing everything they can to prevent this in the future. Those patients who do go home, if you can give them an action plan of what to do, can be really helpful in how and when to use rescue medications. If you're able to get them with a neurologist, that's also been shown to decrease overall seizures if you're able to have them follow up there. And then really that education piece is important. So safety, um, when to seek help, all are really important to do. There's a lot of often like held beliefs in families about how you take care of children with seizures, and being really clear with families, don't put anything in that child's mouth, put them in that safe position, get help. Next slide. So back to that case that Dr. Asha brought up in the beginning. So this is in our last couple minutes here, hoping to get a little bit of participant interaction. So we were talking about a 14-month-old female who was brought to the hospital and they're actively seizing. So there's kind of a couple of things we think you might be considering for this patient. But what you notice on your very brief exam is there's significant bruising on the scalp and there's some um, like deformity of the skull. So in this actively seizing patient, what are, I guess, a couple of your priorities? And if anyone wants to, I don't know if you want to have it raise your hands, or I don't know, Humphrey, how you want to have someone be able to speak.
Yes, so you can, for any participant that has an answer or wants to respond, they can either unmute and speak, or you can also write the answers on the chat and we'll definitely see them.
Yeah, and anything in the chat, I'll call out.
So you're all welcome to participate. Feel free. You can just write what you think
Yeah.
could be the response in the chat, and we'll see what you write.
Yeah. If anyone has a specific seizure cause that they're thinking about, or some of your treatment priorities, what your first step would be. Great. So, Mira mentions that this patient, just with those findings, was worried about trauma. So, making sure as we're treating the seizure, make sure you evaluate the patient for trauma, both accidental and non-accidental. Yeah, Winnie's also saying thinking about head injury in kids, also really important. Great. Yeah, again, this highlights your physical exam and why doing that can help really make sure your approach is not missing things. Yep, ABCD approach with trauma care in mind. I love that. Thinking airway, breathing, circulation, disability, and dextrose, and exposure. So really valuing that patient head to toe. Stop that seizure. Love it. Well, great. Well, thank you guys. Oh, bruising could be a sign of trauma, also seizure itself. Great thoughts. Yeah, the idea of maybe that child got injured and that's what precipitated the seizure, or maybe they were seizing and fell or were injured in some way. Great. All right, next slide. All right, so just wrapping up, really important to sort of identify that seizure early as possible. Always go back to your ABCs. You know, we learn all this really cool stuff and all that background, but without that really appropriate ABCD management, we won't be able to be successful in stopping seizures. And then make sure you go to your anti-seizure medicines early and in a timely manner. And time is brain. Follow your algorithms and stay calm, like this very calm baby. All right, thank you.
Yep. Thank you very much, Dr. Asha and Dr. Colleen, for a very nice presentation about approach to pediatric seizure in the emergent setting. So we still have 4 minutes. So I'll now like to welcome anyone who has a question or a clarification to our presenters. You can just put it on the chat, or you can also raise your hand and we'll unmute so that you can ask and speak.